Hello, my name is Ross McMahon and I'm a consultant cardiologist with McMahon Cardiology, and I primarily work in Peninsula Private Hospital. So today I'm going to speak about atrial fibrillation, and primarily I'm going to be discussing what role a GP has if they newly find out someone to have atrial fibrillation, and I just wanted to come up with a program for how they would deal with it. Sorry, I thought there would be a 4-step program for when they newly diagnose someone with atrial fibrillation. The first step would normally be to assess the patient in front of you, and especially looking for signs and symptoms that might lead the doctor to believe that the patient might need investigation sooner rather than later. So certain signs and symptoms that we would be concerned about would be hypotension, so a blood pressure less than 90 millimeters of mercury systolic, a tachycardia, so a heart rate greater than 110 beats per minute, an irregular pulse, also signs of angina or signs of breathlessness at rest. Any of these features that you would determine initially from speaking to the patient would make you think of maybe an earlier referral. So the first thing is to assess the patient in front of you. The second thing would be to consider what investigations that you might want to put forward. The first investigation that you would want to arrange would be an echocardiogram. An echocardiogram obviously looks at the structure of the heart, and there's several features on an echocardiogram which are really important when atrial fibrillation is diagnosed. First of all, we want to see what the size of the left atrium is like. This will give us an idea of whether rate control or rhythm control will be the preferred treatment moving forwards. Secondly, it's very useful to see whether the LV function is normal. Often patients with undiagnosed atrial fibrillation can develop a tachycardia-induced cardiomyopathy, whereby the heart weakens because the heart rhythm has been at a fast rate for a long period of time. Also, we will look out for other valvular issues such as mitral regurgitation. This is often a precursor to atrial fibrillation, and it's important to work out whether there's structural issues with the heart. Finally, we would look out for pulmonary arterial pressure, which is also a feature that maybe there's associated valvular disease. The next feature that really would be important would be to consider anticoagulation for the patient. This is probably one of the most important things you can do, and especially to treat someone prior to them seeing a specialist. There are several anticoagulants that we tend to use. These are novel anticoagulants. We don't tend to use warfarin anymore. The 3 in Australia we tend to use would be dabigatran, apixaban and rivaroxaban. These should really be initiated immediately upon this diagnosis, and this is to reduce the risk of ischemic stroke. The next thing that I would consider and that should be in a GP's algorithm is wondering when they should refer for specialist care. And really, I think an initial consultation with a specialist is important, because then we can quickly work out which treatment algorithm to go down. The major treatment algorithms to go down are either rate control or rhythm control. Rate control for atrial fibrillation is if you decide that you don't wish to restore normal sinus rhythm. So this would be sometimes for our more elderly patients, for patients who seem to be tolerating the arrhythmia quite well, or for patients who an echocardiogram has shown an enlargement of the left atrium, and we think therefore it's unlikely that any of our treatment to restore normal sinus rhythm would be successful. If that's the case, we would tend to use standard drugs such as a beta blocker or digoxin to slow the heart rate, in addition to the anticoagulation. We also sometimes would give a diuretic if the patient is fluid overloaded. If, however, the specialist feels that rhythm control is more important, we would embark on a treatment strategy that may include a DC cardioversion in order to restore sinus rhythm, or we may feel about the use of antiarrhythmic drugs, or we may use a higher advanced technique such as a ablation in order to restore sinus rhythm. If we do restore sinus rhythm, then often we're able to stop anticoagulation. So this would be the mainstay of a treatment algorithm for a GP who diagnoses new atrial fibrillation. So just to recap, the main features would be assess the patient in front of you for important symptoms. Secondly, consider anticoagulation, even before specialist involvement. Thirdly, consider investigations. And fourthly, consider referral to a specialist. With regard to investigations that a GP would consider to organise once the diagnosis of atrial fibrillation has been established, I think that an echocardiogram would be the most important. The most important reason for this would be to look at features such as left atrial size, the presence of other valvular disease, the presence of LV dysfunction, or elevated pulmonary pressures. The next investigation that I think would be worthwhile would be ruling out obstructive sleep apnea. Sleep apnea is a very common condition that we see, especially in Australia, with increasing amounts of obesity. One such thing would be the presence of apnea, which is where there are long pauses between breaths. As you're aware, during these apneic episodes, the glottis is closed due to soft tissue falling back on the throat and covering the trachea. Unfortunately, when this occurs, there is a reduction of oxygen levels in the bloodstream, so therefore people become hypoxic, but also there's a rise of carbon dioxide levels, and over time this will cause the patient to wake up. They will therefore have disturbed sleep. They will yawn or snore, and therefore they won't realise that they've had a poor night's sleep. There will be daytime somnolence the next day and overall fatigue levels. But one of the other features of sleep apnea is it increases the risk of atrial fibrillation. Often atrial fibrillation is a marker that sleep apnea is present. Another test that's very important to order would be a Holter monitor. A Holter monitor is a test in which we can monitor for arrhythmia, but we can also monitor for the overall heart rate. The overall heart rate in atrial fibrillation is actually very important. The reason for this is that a lot of people with atrial fibrillation don't mind the fact that the heart is out of rhythm. They're more concerned about the fact that the heart is going fast and it feels uncomfortable to them. Interestingly, when we perform Holter monitors on people, we can determine how important it is that they have antiarrhythmic drugs. If we're going for rate control, a number of 110 beats per minute is a key indicator. If the heart rate is on average greater than 110 beats per minute, there's an increased risk of a tachycardia-induced cardiomyopathy. In other words, the heart muscle will weaken as the heart rate is too fast. A simple analogy is like running around a 400-meter track. The faster you run, the quicker your legs will tire, and therefore the faster your heart rate is, the above 110 beats per minute, the likelihood is that you will develop a tachycardic-induced cardiomyopathy sooner. Also, the slower the heart rate, the better the patient will feel, and we will aim to get a heart rate around 60 beats per minute. Therefore, in a Holter monitor, if the heart rate is 80 or 90, that will not cause a cardiomyopathy, but it will let the cardiologist know that optimization of heart rate lowering medication would be important. Another test that would be important to arrange would be some sort of test to rule out ischemia. One such test would be a CT coronary angiogram. Often, atrial fibrillation is a disease process that can occur on its own, but often it can occur alongside coronary artery disease. There are certain tests that we would use for coronary artery disease in patients without atrial fibrillation, such as a stress test or a stress echocardiogram. However, sometimes in newly diagnosed atrial fibrillation, people are quite symptomatic. And it can make it a challenge to look for ECG changes, and also patients will not be able to walk for the 9 minutes required on a treadmill that we would normally ask people to walk for. Therefore, in situations like that, a CT coronary angiogram, where we directly use the CT imaging to look at the coronary vessels to look for underlying atherosclerosis, is very important. And again, it may be that atrial fibrillation is being well tolerated, however, it's a useful marker to look for disease elsewhere. Another test would be a coronary angiogram performed invasively, such as our facility here in Peninsula Private Hospital. However, there is a risk with an invasive procedure, and often with patients it's preferable to perform a non-invasive test such as a CT coronary angiogram. Other important tests, of course, would be blood work that should be performed when atrial fibrillation is initially diagnosed. This is important for several reasons. First of all, renal function is very important when we're deciding on the doses of drugs, such as digoxin or anticoagulation. The main anticoagulants have different doses depending on renal impairment. Another important blood test would be a full blood count. Often with anticoagulation, there's the risk of increased bleeding, so it's important to know what a patient's baseline blood work is. Another important test would be thyroid function. Thyroid function is important because, again, atrial fibrillation may be a marker that the thyroid axis is off, and in fact the patient may have thyrotoxicosis that is subclinical and hasn't yet been diagnosed. Other important tests would be iron studies, because again there is an association with anemia and atrial fibrillation. One other feature that's important that I would like to mention is regarding anticoagulation. Anticoagulation should be started initially by a general practitioner, ideally before they see the specialist. But one of the important things is to work out the risk of thrombus versus the risk of bleeding. In order to do this, we would use two scores. The first is the CHADS-VAS score. The CHADS-VAS score is a score that we find very useful in cardiology for working out the risk that a patient would have of developing a thrombus. Thrombus formation is the major concern initially with atrial fibrillation. Often when atrial fibrillation is occurring, the atria don't contract normally, and instead of a slow, strong rhythmic contraction, you can get fibrillation of the chamber. I equate this to like a stagnant pond whereby thrombus can form, and then some of the clot can break away and go to the brain and cause embolic stroke. So the main reason that we use anticoagulation is to stop this stroke from happening. But one of the concerns is that a lot of our patients do have issues such as diabetes and renal impairment, and they can be at a high risk of bleeding. So often GPs will have to decide, is the risk of bleeding worse than the risk of thrombus formation? So how do we come to this decision? And it's by using the CHADS-VAS score, working the risk of thrombus, versus the Has-Bled score, which determines the risk of bleeding. It's important to state that the Has-Bled score, even if it is high, wouldn't stop us using anticoagulation. However, it would indicate to us that a patient should be reviewed in the clinic more frequently than normal to assess their ongoing bleeding risk. With regards to the CHADS-VAS score, this is a score that looks at congestive heart failure, diabetes, age, prior stroke, and male and female sex in order to determine what your risk is. A CHADS-VAS score of 0 in a man or 1 in a woman would be a low score, and we would not use anticoagulation. Any score though above that, we would commence anticoagulation. To summarise, I think that atrial fibrillation is an extremely common diagnosis. It's probably one of the most common diagnoses that a cardiologist will see. And as we have a generation, or as we have patients that are becoming older, I think it's a diagnosis that is going to be made a lot more frequently in GP practices. I think therefore that GPs can very easily look after atrial fibrillation in the community, but I think that it's very useful to keep in mind a four-step approach, especially in the setting of newly diagnosed atrial fibrillation. Again, the first step would be to assess the patients in front of you and looking out for any key parameters such as hypotension or tachycardia, breathlessness, evidence of peripheral edema or angina, symptoms at rest. Any of these key features, I would encourage the GP to look for an early referral to a cardiologist. The next three things that I would want the GP to consider would be what investigations that they need to arrange, and again these would be including an echocardiogram, a Holter monitor, sleep studies, blood work, and studies for ischemia, including a CT coronary angiogram. Next, I would want them to consider anticoagulation. Anticoagulation, as far as a treatment, is the earliest treatment that will make a big difference, and we would really want anticoagulation treatment in the initial phase before the cardiologist is involved. They could consider rate limiting drugs such as beta blockers and digoxin. We would tend to hold off other antiarrhythmics such as amiodarone and sotalol as the patient is not yet anticoagulated, and there would be a risk of thrombus formation and stroke if a patient is reverted chemically without proper anticoagulation. The final thing in this acute phase would be for the GP to consider specialist referral. And at that stage, the GP's referral will start the patient down an algorithm that will either include rate control or rhythm control. Again, rate control for patients who are slightly older and less mobile, rhythm control for younger patients. And again, that may take the form of antiarrhythmic therapy, a DC cardioversion, or more advanced therapies such as catheter ablation. A final step on catheter ablation is that over the last few years, it has been a technique that has been used more successfully and has been potentially curative for many of our patients.